You had a good week. The class reps did communicate that you'd have a class. So I hope others are. In the afternoon, I'm having an exam, the 5-2. So we are now 44. I think those are the ones who are ready to learn. So I think we kick off from 7:30. So we've already started on the general anesthetics. We've done classification as per the nature of the general anesthetic. That's where we talked about volatile. Talked about the volatile ones. We talked about the intravenous ones, and then we talked about also as per their mode of action. So we have classified this. We have classified the general anesthetic. We talked about those ones which are given by inhalation, those ones that are given by through the intravenous route, not as their mode of action, but mode of administration. Then we did mention, as per their nature, are they volatile or non-volatile? When you look at it, of course, the classification has some intersection somewhere, but we're able to look at that. We're able to look at the various classes. We started with the gases, nitrous oxide. We went to the halogenated hydrocarbons, halothane. We mentioned some of the ethers, enfluorine, isofluorine, and so on. We even did mention the SAR of the halogenated hydrocarbons. And of importance, as we said last time, is that when N is more than 2, at least one of the carbons, terminal carbons, must contain a hydrogen for these compounds to have activity. We also did discuss halothane. Actually, we were discussing halothane, the structure. We did mention that out of the volatile general anesthetics, it is one of the general anesthetics that has the highest blood gas partition coefficient. And if it has a very high blood gas partition coefficient, it means it can remain in the blood for a slightly longer time, meaning one, its induction will be slow, two, recovery will also be slow, as compared to the others, which we did mention are the ethers. But we did mention it is stable. We did discuss the role of the halogens. We did mention that when you add halogens, there is increase in potency. The higher the atomic number, the higher the potency. But then we did disqualify that point to explain why most of these volatile ethers or volatile halogenated hydrocarbons have mainly fluorine, and we say it's because of the toxicity, that indeed fluorine causes the least hepatotoxicity, the least arrhythmias, and because it causes the least arrhythmias, gives good volatility, it also helps the molecule also to have high potency, to be non-inflammable. Then you find that although it will not increase the potency as high as the other halogens, it is more preferred because of the toxicity. Because when we look at the molecule, we do not only look at its potency. We are interested in looking at the benefit-risk ratio. When you look at the benefit-risk ratio, we are also looking at the toxicity of that molecule. I think we were able to go up to there. So I hope you'll be able to finish halothane this morning and then continue with the others. You see how far we'll go. That was just a simple recap of what we had looked at last time. So let us start from here, although we had done this slide, but so that we can be able to, the information can flow properly, we can still start from this slide. So we are still looking at the inhalation pulmonary anesthetics, and these ones, of course, include the halogenated hydrocarbons, an example being halothane. We did mention, like cyclopropane, we said it is highly explosive. Of course, initially, when there were no better drugs, it was used. But with drug development, toxicity, and low potency become obsolete as you develop new molecules that have better activity. And that is why drug development, drug discovery and development is a continuous process to try and improve on the existing molecules or to develop new molecules that have better activity. So halogen, enfluorine, isofluorine, sevofluorine, we mentioned some of them, and desfluorine are all halogenated hydrocarbons that differ. Of course, they are halogenated. These ones are really not halogenated. Halothane is the proper halogenated hydrocarbons, whereas enfluorine, if you are going to be very specific, isofluorine, sevofluorine, desfluorine are actually halogenated hydrocarbon ethers. So we can have halogenated hydrocarbons and halogenated hydrocarbon ethers. And what do they define? We did mention, and we know they will define their chemical composition, they will define their physical properties. They will differ, once they define their chemical composition, they will also define in their biotransformation. And I think we had already mentioned like halogen. I hope I've not gone back too far, because I remember we had even mentioned the metabolism of halogen. Which was our actual last slide? Have I gone too far back? Class, kindly guide me tafadhali. I have used a different presentation because I realized the one I was using did not have all the information. Guide me. Have I gone too far back? Guide me tafadhali. Have you noted? Guide me. Are we okay? Or we had gone a little bit further?
Last,
Eh?
no,
Eh?
that's the last, the slide
Oh,
that you're using, the one that ends with my post bronchodilation.
that ends with yes, yes, yes. So we are okay, Nekesa.
Yeah,
We are fine. We are fine.
yes, yes.
Okay, good. Thank you very much. Thank you very much. Thank you for that. Because there is no need again of going back. So therefore, we are just make that correction. Yes, they are hydrocarbon because they have the hydrocarbon portion. But very specifically, if you want to be very specific, we have said we can call them halogenated hydrocarbon ethers. And for sure, they will differ in their mode of in their biotransformation. We are going to discuss that. They will differ in their potency. They will differ in their rates of uptake and elimination. Those are areas that this compound differ. We had actually this slide we had discussed. We had talked because they are volatile. You must use specialized vaporizers. And that is what makes this drug sometimes a bit expensive. And as you mentioned about desflurane, which is not very stable as a liquid at room temperature, and therefore it requires a very specialized vaporizer, and therefore it becomes quite expensive. Halothane is not an irritant to the respiratory tract. That was a requirement for an ideal general anesthetic, which we had already mentioned. Respiratory depression is a consequence only of high concentrations of halothane. So even as we talk about toxicity, let us always note that toxicity is a factor, all is contributed or is depends on concentration. But unfortunately, it can cause bronchodilation. It can cause a bronchodilation. Halothane has the highest blood gas partition coefficient of the volatile anesthetic agents and is pleasant to breathe. So as we mentioned that it has the highest blood gas partition coefficient, we did that explain to us. It can stay in the blood a little bit longer. It doesn't leave the blood very easily to get into the brain. When now it comes to be excreted through exhalation, it does not also leave the blood very easily. So it can have low induction, and also it can have a low recovery. Its recovery can be slow because it has a tendency of being more soluble in the blood than in the gas. And we are going to mention that as we move on, even for the other ones. It reduces cardiac output more than any of the other volatile anesthetic. But it is one of the cheapest, perhaps the one which is affordable for most of our population. It may cause also a major disadvantage of halothane. And not only halothane, even the other ones, but halothane was found to be the one which causes this toxicity to the greatest extent because of its metabolism. So it can trigger what we call malignant hyperthermia in those who are genetically predisposed. So not everybody. But now the question is, as I said last time, you will not know who is genetically predisposed. So if you give it, and it is said of one of the very important, he was a comedian who was called I think Mutai or something. We used to call him Pajero in our early years, and he had a lamp, a big lamp behind. It was just an adipose tissue. You have seen like some people who are behind their head there, they have a big adipose tissue. So he was going in to have it scaled down. He was not sick, but it is rumored that he had halothane toxicity. And unfortunately, it was rumored that perhaps they did not have the antidote, because you do require the antidote if the patient is going to survive. So we are talking about one of the disadvantages of halothane is malignant hypothermia in those who are genetically predisposed, and you will not know who is predisposed. Malignant hypothermia is rare, but you can see, just as we discussed about chlorophenico-aplastic anemia, yes, it is rare. Unfortunately, it is life-threatening clinical syndrome of hypermetabolism involving the skeletal muscle. It involves the lining muscle, which releases calcium ions. So I think, again, you are going to do a lot of that in pharmacology, but as I just mentioned, so that now when you come to pharmacology, you will do the other details. In susceptible individual, this reaction is triggered primarily by exposure to the volatile inhalation or anesthetic agent and succinylcholine, which is a muscle relaxant. So when you get exposed to those two drugs, one being a muscle relaxant, the other one being the general anesthetic, then you can do the next. In patients who are susceptible to malignant hypothermia, the renodyne receptor in the skeletal muscle is abnormal. So they have that receptor which is abnormal, and this receptor is responsible. It's a calcium ion gated channel responsible for releasing calcium during contraction and relaxation. So when you have an abnormal one, it releases a lot of calcium and therefore causes a lot of it causes excessive muscle activity, and in that you get what you call the malignant hypothermia. So in patients who are susceptible to malignant hypothermia, the renodyne receptor in the skeletal muscle is abnormal and causes a buildup of calcium in the skeletal muscle, resulting in massive metabolic reaction where you have relaxation or contraction, relaxation upon exposure to the triggering agent. And as we have said, one of the triggering agents can be halothane. Malignant hypothermia must be treated rapidly in order to avoid the fatal outcome. So it is good to note some of this, whether you are learning them in Pharm Chem or you are learning them in ecology or in clinical pharmacy. Knowledge is knowledge. And sometimes you find that the various lecturers, we mentioned those points. Then, so that is malignant hypothermia. It is a rare, we can call it a rare. We used to give them a name, I will remember that name. It's a rare adverse event, idiosyncratic. It's a rare, we can call it an idiosyncratic event. It's a rare event which can happen, and once it happens, it can be fatal, not unless you have dantrolene, which is indeed the antidote for that effect. And then it can also cause hepatotoxicity. So that was a muscle reaction. Now it can also cause hepatotoxicity, and the hepatotoxicity of halothane is because of its metabolism. I think we did mention the acetyl chloride. The acetyl chloride being a very potent electrophile, and being a very potent electrophile, it can add to your tissues in the liver where the metabolism is occurring, or it can add to the sulfhydroenzymes or any nucleophilic enzyme. And when it adds to any nucleophilic enzyme, when it adds to your liver tissues, it will result in hepatotoxicity. So it's important for us to know those kind of challenges that can occur with this very, very, one of the affordable volatile general anesthetic. Halothane undergoes oxidative metabolism through cytochrome P450, especially cytochrome 2E1 and cytochrome 2A6 enzyme, giving trifluoroacetyl chloride. And you can see it's trifluoroacetyl chloride. The carbon has a very high positive charge, or it has a delta positive charge, and therefore very strong electrophile. As the major metabolite, trifluoroacetyl chloride results with N-terminal amino groups of the liver reacts with the N-terminal amino groups of the liver proteins, including the cytochrome 2E1 itself, to give the N-trifluoroacylated protein adduct, and that is what will result in the hepatotoxicity. The resulting protein modification results in the formation of neon antigens, which elicit immune response. Again, in susceptible patients, eventually causes liver necrosis and fatal consequences in rare cases of patients. So again, you have those who are very highly susceptible. They are genetically different. There are those who will be highly susceptible, and they can get These are the condition. The other one was malignant hyperthermia. This is hepatotoxicity. The protein modifications from the halogen adducts presumably result in hapten formation, leading to induction of immune response and hepatitis. Remember, some of the molecules in the body, and we mentioned this when we were looking at the beta lactams, when they undergo protein, when they bind with protein, initially the compound is small enough, but when they bind with the protein, they form protein adducts, even in the blood, in the plasma. Then you find that whatever molecule that is formed, the hapten is big enough. It is big enough to trigger an immunological or to trigger an immune response. And that is how you find these compounds bring about their toxicity. This is happening in the liver because that is where the metabolism of this compound occurs. The clinical features of halogen-induced hepatitis are consistent with immune-mediated advanced drug reactions. Halogen has greater hepatotoxicity than both enflurane and desflurane. But you see now, as I have said, the danger or the problem with these drugs, the better the drug is, the more expensive it is. And therefore, usually, you use those other safer drugs for the ones who can afford, but for the ones who cannot afford normally, or if you go to most of those hospitals, you will find indeed they do have, they use halogen, but you have already gone out there, you should be the one informed. You haven't been out there for quite some time. The relatively lower toxicity associated with enflurane and desflurane, we are going to mention later, anesthetics may be due to their lower rate of metabolic bioactivation. So halogen is metabolized very fast into the toxic trifluoroacetyl chloride. But when you look at enflurane with its isomer, the isoflurane and desflurane, they are metabolized into the active or to the electrophile much more slowly, and that helps us to that helps the enflurane, the desflurane to have lesser toxicity than halogen. The reactive acid chloride, which we already mentioned, the trifluoroacetyl chloride, is formed at significantly lower levels for enflurane and desflurane than for halogen. That explains everything very clearly. And sometimes I hope and wish that you would also take your time, and if you need to explain in the same manner. So this is what we are looking at, that we are starting with halogen. This is our halogen. And as you can see on this position here, there is a hydrogen. It has a hydrogen on that position, and because of that hydrogen, it can undergo oxidative hydroxylation catalyzed by cytochrome 2E1 and 2D6, and in the presence of oxygen, to give us, you can see these square brackets, making the compound very, meaning that compound is unstable. And you can see it has that hydroxyl group, and there can be a shift of electrons, and there's the electron shift. I still feel I have done all this, but as the electron shift, then there will be loss of bromine. And the bromine rather than chlorine is lost because you have other steric factors that influence which molecule will be lost. We know chlorine is more stable as a chloride ion than bromine, but the bromide ion is lost fast, as I have said, the other steric factors and other electronic factors that controls what is lost. So this is now the compound you get, the trifluoroacetyl chloride. And this can also react with water to give us the trifluoroacetic acid. And whether you have the trifluoroacetic acid or the trifluoroacetyl chloride, each of them, because you see, this is putting electrons that way, this is putting electrons, these are fluoro groups putting away electrons. So this carbon there will have a positive charge, and because of that positive charge, that chloro group, that carbonyl group or oxo group, or that carbon of the oxo group will have a positive charge, and that positive charge is what will add. So we are looking at this protein, and the protein has an amino group. So this group there, so this amino group, remember, we start from the position of high electron density. The nucleophile will attack the electrophile with loss of carbon, of the chloride ion, and of course with the acyl group being added into the protein, and that is what is giving us the compound that is big enough, the hydrogen hapten that now can trigger. As you can see, that is the hapten that can trigger now the hepatotoxicity that is caused by these drugs. And as we have said, yes, not most of them, even the others, the enfurin, the desfurin, can still undergo that metabolic process, but at a slower rate. And once they undergo that reaction at a slower rate, they will have lower toxicity compared to halogen. Halogen also undergoes other metabolic processes, which we call the reductive metabolism of halogen. The other one was oxidation. It can also undergo a reductive metabolic process. This will happen when you have oxygen tension, or when you have low oxygen levels. So under low oxygen concentration, halogen undergoes reductive metabolism, again catalyzed by cytochrome 2 and 6. So we can still say catalyzed by cytochrome P450 enzyme in human liver microsomes. The reductive metabolism forms an unstable 1-chloro-2,2,2 trifluoroethyl free radical. And this is the first one here. No free radical has a dot. 1-chloro, the position 1, position 2. The position where you have the substituent, you give it 1. So 1-chloro, 1, 2, 3, 2, 2, 2 trifluoro free radical. And we know that free radicals are also very destructive. They are highly reactive. So once you form that free radical, very, very reactive, and therefore it can also bring about a toxicity. Reductive metabolism forms an unstable 1-chloro-2,2,2 trifluoro free radical that serves as an initiator for lipid peroxidation. So it serves as an initiator for lipid peroxidation, with consequent adverse effects on respiratory and circulatory function, because it also is an electrophile. It has electron deficiency. So again, it would attack the lipids and bring about a lot of toxicity. Further, this free radical is also a source of the other volatile metabolites like chloro-difluoroethane. So you look at this is chloro, difluoro, this is difluoroethene. So all that has happened, you have lost one of the fluorines, and that electron that is left behind couples with this radical, with that free radical, to give us a double bond, to give us the volatile metabolite chloro-difluoroethene, or it can also give us a chloro trifluoroethane. So here you do not lose the fluorine. It is just a matter of us forming the free radical somehow joins or extracts an electron from another part to give us the chloro-trifluoroethane that may show also other adverse effects. So what we are saying here is that it's important to appreciate that halogen undergoes oxidative metabolism and also reductive metabolism, and both of them can cause adverse effects. Then we have also mentioned F-enfluorine, and we have also mentioned isoflurane. As having said already, isoflurane is a positional constitutional isomer of enfluorine, and that you already know. Metabolism of enfluorine proceeds again via reactive intermediate that either react again with water to form the acid, just like in halogen, that is excreted in urine as a glucuronide conjugate, or binds covalently to the liver proteins to form the protein adducts. If you have understood halogen, it is only that the product is different, because again, the structure of halogen and the structure of enfluorine or isoflurane are different. And we said they will undergo different metabolic processes because they have a different structure. So I think that is quite okay. Again, the metabolism is characterized. Cytochrome 2E1 is never a good enzyme. Remember that enzyme, even when we were discussing metabolism of paracetamol, the cytochrome 2E1 was still a very dangerous enzyme. Cytochrome 2E1 mediated oxidation of isoflurane, and this is the same one that was catalyzing metabolism of halogen, proceeds via reactive intermediate to form trifluoroacetyl chloride. This is not correct. It should be, let us correct it, and it should be difluoromethoxy difluoroacetyl chloride. So please correct that. This is the one for halogen, but for enfluorine and enfluorine or isoflurane, to give us, now it will just be the positioning of the groups. It will give us the difluoromethoxy difluoroacetyl. difluoroacetyl chloride, not the trifluoroacetyl chloride that is formed with halogen, difluoromethoxy, difluoroacetyl chloride, which gives covalent modification. Again, that compound, as you can see, difluoromethoxy, difluoroacetyl, it is this compound here. It's this compound here, difluoromethoxy, there, difluoro, here, these are the difluoroacetyl and the acetyl, because of those two carbons, acetyl chloride. So again, the metabolite is just because of the structure. And again, as we look at that structure, the fluorines are electron withdrawing. The carbonyl group, so the whole of this group is electron withdrawing. This group is electron withdrawing. That group is electron withdrawing. That group is electron withdrawing. So what is the fate of this carbon there? The fate of that carbon is that that carbon will have a positive charge, although it could just be a small positive charge, but it will have a positive charge. And because of that positive charge, then this carbonyl group can be attacked by nucleophiles and with release of the chloride. And when that forms, it is the same thing. It will form the adducts, as we have mentioned, of halogen, and those are the ones that will be responsible for the toxicity. It is only that we have said the rate of formation of the difluoromethoxy, difluoroacetyl chloride is not as high as the rate of formation of the trifluoroacetyl chloride of halogen, and therefore the N-fluorine has lesser toxicity compared to halogen. Then we look at desfluorine, and it's the same, but of course the structure is again completely different. And because of the structure, we will see the structure somehow is able to give desfluorine stability against oxidation. So when we look at desfluorine, that is the structure of desfluorine, and you can see that it has this trifluoromethane substituent, which you do not find in the other compounds. So you have that trifluoromethane substituent, and then you have a fluorine, and then you have an oxygen, and then it is metabolized. It can be metabolized again. If you look at that structure, as we have already discussed, it still has a hydrogen, and because of the hydrogen, then because of the presence of a hydrogen, this carbon here has a hydrogen, and because of the presence of that hydrogen, and then we can have oxidative hydroxylation, as you can see in the next one. So this hydrogen there undergoes oxidative hydroxylation, and once it undergoes oxidative hydroxylation, the resultant compound is very, very unstable, and it's very, very unstable. It loses a molecule, it cleaves. So it's kind of there is sort of cleavage. You can see you're losing a whole difluoro. It is how many carbons? One. Difluoro. It should be difluoromethanol. You can see, you can name it better, but you can see it has it is C, a fluorine, and then it will have a hydrogen, and it will have an OH. So you can see it is a derivative of methanol. It is indeed a derivative of methanol, and that is lost. So in other words, we are losing the whole of this. So this one results in a cleavage such that you have loss of that. And again, you can see the compound that you get, again, a compound that is highly electrophilic, a compound that is highly electrophilic. And now this is a compound that acts as an adduct. So, but fortunately, the rate of metabolism of desfluorine, as we are going to mention, is much again slower than that of N-fluorine and isofluorine, because is qualitatively similar. The magnitude of breakdown of desfluorine is quantitatively less compared to isofluorine. Why? Desfluorine resists biodegradation more than any other contemporary volatile anesthetic. So the issue is here that desfluorine is able to resist the oxidative metabolism compared to the other compounds, and stability, then it will have less toxicity, as you'd expect. Then the synthesis, I think we mentioned that later. We'll give the reasons later. And this is a simple synthesis of enfluorine, 2-chloro-1-difluoromethoxy 1,1,2-trifluoroethane. This again, you need to go back to your UPAC system. Is a regio isomer of isoflurane, as we have already mentioned, a specific area. That's what we're calling a regio isomer. It is a positional isomer. There is shifting of some groups from one carbon to the other to give us the enfluorine or isoflurane. It is synthesized on industrial scale by free radical chlorination of methoxy 1,1,2-trifluoro-2-chloroethane. Again, look at that structure. I don't want to go into, you can't be able, I've given you the name, kind of find out why it has that name. You're using the UPAC system in the naming system. And that compound we are saying, on industrial scale by free radical chlorination of that compound, followed by halogen or chloride to fluoride exchange. That is halogen, that is chloride to fluoride exchange in the presence of hydrogen hydrofluoric acid and antimony. So if you look at that, that is what we are starting with. And once you start with it, we have said it's a free radical chlorination. So you can see this F that remains the same, that group F oxygen remains the same, but this methyl group is the one which is undergoing radical chlorination, and you can see two of the hydrogens are replaced by chloro groups, but of course here we still have one hydrogen left. And then now we are saying it is an exchange of halogens. You exchange chlorine for fluorine using hydrofluoric acid and antimony, and that gives you enfluorine. So again, it is not a very difficult method of synthesis, and I think it has also been well explained. The particle effects of desflurane, I should have gone to this first. Sorry for that disorganization. I should have gone to this first before going to the synthesis. So we have already mentioned that desflurane is more stable. It resists oxidation through cytochrome P450 enzymes. So that's what we want to understand. So desflurane undergoes limited biotransformation, that is biooxidation, to form the trifluoroacetic acid as a metabolite. Trifluoroacetic acid as a metabolite. We remember we said desflurane, when there is the oxidation to form the hydroxyl metabolite, there is a cleavage where we lose the ethanol. I think the trifluoro, we lost, I don't know whether it was, we lost it as a difluoro. Let us go back again. We lost it as a difluoro. We can actually call it difluoromethanol. We actually lost it as a difluoromethanol because you can see you have those two fluoro groups there. And the compounds we are getting is it has a trifluoro there. You can see trifluoro acetyl fluoride. The other one was trifluoro acetyl chloride, but you can see this is trifluoro for this, trifluoro, 1 carbon, 2 carbon acetyl fluoride. And that trifluoroacetyl fluoride is too reactive. But we are saying, for when you look at this, so it should be, sometimes this is a mistake to form, so we are seeing should be the trifluoro. Yeah, it should still be trifluoroacetic acid when it undergoes, yeah, that's correct. When it undergoes reaction, if this one now undergoes reaction with water, it will lose the fluorine. So it will still give us CF3, C double bond O. OH, it's always good to confirm that's correct. So it will still give us the trifluoroacetic acid, just like halothane. But even if it does not react with water to give us the trifluoroacetic acid, the trifluoroacetyl fluoride in itself is already a strong electrophile, which can bring about adduct reactions. But we are saying, when we compare desflurane, enfluorine, and halothane, we are saying desflurane is a little bit more stable. It resists, as I have already mentioned, it resists oxidation or the biotransformation to form the trifluoroacetic acid as a metabolite. I wanted us to go back so that we established that indeed that's what it forms. Desflurane exerts hepatotoxicity, although to a lower level than that of both enflurane, halothane, and even isoflurane. The mechanism of hepatotoxicity of desflurane again is similar to that of halothane, enflurane, or isoflurane, because it is through the metabolism that you form the active, the reactive metabolite, which can bind with the tissues. Cytochrome 2E1 oxidation of desflurane is also the formation of an unstable intermediate, which upon elimination of difluoroethanol, as we had already mentioned, is the one which it gets out. The difluoroethanol gives, was it difluoroethanol? And I'll again go back. Sometimes I can also make a mistake. To me, this is not difluoroethanol. This is the difluoromethanol. It has only one carbon. Difluoro. Can you see that, class? It's good also to check. Sometimes error is human. If you look at this compound, it's not difluoroethanol. It is difluoro. Ethanol has 2 carbon atoms. This is only one. So I think, again, kindly correct that. It's a small mistake there. It should be elimination of difluoro. It should be difluoromethanol, not ethanol, to give trifluoroacetyl fluoride. So kindly correct that small mistake there. It should be difluoromethanol, gives trifluoroacetyl fluoride that rapidly react with protein side chain amino groups to give the protein adducts. Again, that's a song. I hope you can be able to understand that. The cytochrome oxidation of desflurane is less favored as compared to that of enflurane. And that is now what is most important, because we are saying desflurane is more stable. And this stability is because of the structure. When you look at the structure of desflurane, one of the substituents is a trifluoromethane group, and that is what is giving it stability. The free radical intermediate formed from desflurane is relatively more stable. Is relatively less stable, relatively more destabilized due to the strong electron withdrawing trifluoromethane group, reflecting its relatively lower metabolic oxidation. So again, this is a qualifier. This is emphasizing the point we said: difference in chemical structure, difference in physical properties, difference in metabolism, and all these are subject to the structure of this compound. So when you look at desflurane, unfortunately, we can go back to look at the structure of desflurane. When you look at desflurane here, this is the group that we are talking about. This trifluoromethane group. That trifluoromethane group is a very potent, very strong electron withdrawer. And because it's a very strong electron withdrawer, it means it results in formation of a very, very highly unstable intermediate. And that highly unstable intermediate, when something is too unstable, it does not exist. The molecule exists, its formation. So that is all we are saying. Because of the structure of desflurane and the fact that it has this trifluoromethane, the intermediate, because you have done about the pathways of metabolism. They go through intermediates, sometimes they go through cations, sometimes they go through free radicals. And we are only saying that when these forms a free radical, the free radical is highly, highly unstable. So the reaction does not happen in nature. It's slow. Because of that very unstable intermediate, when you have a very unstable intermediate, it chooses to revert back to the original molecule. Just remember, again, when we are looking at the beta, at the penicillins, and we did mention that when you look at penicillin, it is not stabilized by resonance because the molecule that is formed is very unstable. So that's the same thing we are saying here. Yes, a few of those molecules will survive, but very few, and therefore that's why we are saying, because of the intermediate being highly unstable, then desflurane is more stable to oxidation, and hence it causes the least toxicity in terms of hepatotoxicity. Desflurane causes minimal depression of the renal blood flow, and there is no evidence of nephrotoxicity, so that's an advantage. Desflurane is unfortunately rarely used, although it has those advantages. It has lower toxicity, both renal and even hepatotoxicity. It's rarely used because of its low boiling point and very high cost of use. So it has a very low boiling point. And once it has a very low boiling point, it has a problem. At near room temperature, a liquid desflurane vaporizes into its gaseous state. It's highly, highly volatile. Unlike the others that at room temperature are liquid, desflurane can start vaporizing at room temperature. So you must use very, very complex gadgets for you to be able to deliver this compound. They ought to, at near room temperature, liquid desflurane vaporizes into its gaseous state. To overcome this characteristic, desflurane use requires a highly specialized vaporizer, and that is why we have talked about its cost of use. So there are many reasons why you might not use a drug. It is stable, but its cost of use is very high. It requires a very specialized vaporizer, and therefore that makes a drug. And this, as we have said, is because of its very low boiling point. The lower solubility of desflurane, the lower solubility also of desflurane contributes to the much more rapid recovery from anesthesia compared with isoflurane. Again, remember lower solubility in blood. It has a lower blood gas partition coefficient. And because it has a lower blood gas partition coefficient compared to halothane, all, or even the others, the isoflurane, it will have much faster or much rapid recovery. That drug, as we are saying, we are not saying it is not in use, but we have said it is rarely used because of that complex of the low boiling point. Again, we mentioned about physical properties. Remember, partition coefficient is a physical property. Remember, solubility, that's of course partition is a physical property. Boiling point, volatility, all those are physical properties. So as even we mentioned those properties, I have elaborated on them to mention some of the properties that can lead to differences in the stability of these compounds. Methoxyfluorine, okay, I need to move a little bit faster. It is non-flammable but unstable. And so an antioxidant preservative must be included. So again, you can see differences in structure, giving us differences in stability, differences in physical properties. We are just emphasizing on the summary that we have done. The blood gas partition coefficient for methoxyfluorine is also very high, blood gas like halothane. So induction, recovery, and rate of change of anesthetic depth are slow because the blood gas partition coefficient, that means at any one time there will be a higher concentration in blood than in the gas. When you exhale that exhalation, or remember the excretion of this is through exhalation, then it will be very slow. Recovery will be slow, and that can be a problem. So induction, recovery, and rate of change of anesthetic depth are very slow. Recovery and rate of change of anesthetic depth are also slowed by a high solubility in the tissues, particularly the fat. So it also has a very high solubility in the fats, high lipid solubility, and therefore that also, in other words, we are talking about deputization of methoxyfluorine in the fats. Again, that slows down its recovery. Methoxyfluorine has a high solubility in rubber and will dissolve in components of the breathing system. So that again is a disadvantage of methoxyfluorine. It is an extremely potent inhalation anesthetic, but you can see it has its own disadvantages for which, when you use it on the patient, you must remember, and that is why we talked about an ideal. We said it must be inert. This one is even reacting with rubber. So that is why we talked about the ideal, so that as we go along, you ask yourself, is that really ideal? It has one or two disadvantages, but nevertheless, we are saying it is also a good volatile anesthetic. So it's methoxyfluorine metabolism, and its metabolism you can is a little bit, looks like it's a little bit different from the others. It can be metabolized through O demethylation, and you can see that group is remaining. O demethylation, that one is remaining, and it's not just O demethylation. Many things are happening there. So you have this group remaining, and this carbon So there is also defluorination to give us the dichloroacetic acid. If it gives us the dichloroacetic acid, that again can cause hepatic hepatotoxicity. So here, although I've said O demethylation, first I'm considering that to be the O demethylation, but that is not all. There is O demethylation that group going, but there is also the O demethylation and dehalogenation also happening at the same time. So it's undergoing O demethylation coupled with other metabolic processes, because you can see you do the O demethylation, which is that one, you're removing the methoxy group, but at the same time, there is not a compound that goes oxidation or defluorination to give us dichloroacetic acid and hydrogen fluoride. And this is this is CH2Cl chloromethane. That is chloromethane. So to give us chloromethane, to give us hydrofluoric acid, and to give us the dichloroacetic acid, again, this compound can still cause hepatotoxicity. So that is one route of metabolism. As I have said, it is not just one, it's a bit complex, just not all demethylation, but all demethylation coupled with oxidation and dehalogenation to give us oxidation and anyway, even all demethylation is an oxidative process. So the oxidative process also results in defluorination to give us that compound. The other one is this is the dechlorination. This is dechlorination, and if you look at that product again, here we are left with the methoxy group. And methoxy group is intact. That group is intact. So in this one, we are just doing dechlorination. I believe also it's an oxidative process where the compound undergoes loss of the chloro groups to give us again methoxy. Again, that is methoxy is still there, difluoroacetic acid. Methoxy difluoroacetic acid. And again, as we have discussed with the other compound, this metabolites can also bring at certain degree, they can also cause hepatotoxicity. So you can be able to understand how methoxyfluorine can cause hepatotoxicity, how N-fluorine can cause hepatotoxicity, how desfluorine, which is the most stable to oxidation, can also cause hepatotoxicity. Desirable effect, extremely potent, powerful inhalation anesthetic that is an excellent skeletal. So we are just mentioning what is good about it. That's an excellent skeletal muscle relaxant. Is also a non-irritant, non-flammable, and non-explosive in air or oxygen. It has a potent analgesic effect and has some post-operative analgesic action. So it has some good activity, but we have also said it can also have some undesirable effect. It produces some respiratory and cardiovascular system depression, but generally less than halothane at comparable depths of anesthesia. The metabolism of methoxyfluorine results in fluoride ion release. Remember, we did mention that you can also have fluoride can also cause renal toxicity release, which may cause renal damage, as we have already mentioned. Relatively high solubility, which causes the patient to make a slow transition back into consciousness, that we have already discussed. So that, again, are some of the advantages and some of the disadvantages of these drugs. And I think I've even gone to quite a lot of details. And I believe that at the end of both the halogenated, actually that is the end of the halogenated. We started with the alkanes, halogenated hydrocarbons, halogenated ethers, and we have given examples, especially their metabolism is very key. It's also important for you to note, even as you add to your pharmacology, the disadvantages of these drugs. Because if a drug, you have given a patient a drug, the patient is out of that theater, they have very slow recovery. That is also a major disadvantage. It has very low induction. That means if you're using it as an induction anesthetic, if the patient get or the anesthetic drug get depression, cardiac depression, that means. So those are some of the considerations you must make when you choose that drug, because again, that is why the history of a patient should be well taken before a patient is taken to theater. You need to understand, do they have a problem? Are they asthmatic? Do they have a problem? Do they have a cardiac problem? Do they have other issues? Are they taking other drugs? So that once, you remember, there's one we said you cannot give it to epileptics. So that now you are careful such that you do not cause death of a patient. And your explanation is that alizidiwa. Na hakuzidiwa. It's the drugs that you gave that brought in a drug-drug interaction, which could have resulted in the death of that patient. We did mention about malignant hypothermia. Dantrolene is the antidote of management of malignant hypothermia. So I thought, let me just mention it for us to understand, because we don't study for the sake of just studying. We also study so that now when you go out there, you have the information. And therefore, when you go to a hospital where they are using halothane as a general anesthetic, you need to find out, do they have the antidote? Because we have said in some of the patients who are genetically predisposed, they can get malignant hypothermia. How are they going to be sorted out? So you as a pharmacist, when you go to that institution and you realize they use halothane, it should be your interest to find whether they have the antidote in stock, because you can have one or two patients reacting to the halothane. So this is the dantrolene, and we can call it an imidazoline derivative. Again, nothing new. Imidazole. We have studied histamine, and you can say we are calling it an imidazoline derivative because you can see when you talk about the imidazole, there are double bonds at certain positions. There are double bonds at certain positions, but of course now what we have done, we have added oxo groups. So we have added oxo groups, and because of the addition of oxo groups, can call what position 1, position 2, position 3, position 4, position 5. At position 5, we have an oxo group. At position number 2, we have an oxo group. Remember, we talked about the different nitrogens. We have actually discussed all these things, and I'm grateful that I'm still the same one who has taught you. So you cannot say you don't know these things. So this is an imidazoline derivative. This is the imidazoline because it is saturated, and therefore it's not an imidazole. It is saturated and lacks the double bond. And then also, if you look at this compound also, then if you can notice quite a number of bonds, you can notice that's an imine bond there. You can also notice this is a group we call the furan. This is the compound, this is the group that when we were talking about ceftriaxone, the furan ring was found in ceftriaxone. Again, as you continue on, it is important to use the knowledge that we have studied. You can see this here. When we were looking at the antiparkinsonian drugs, we talked about the nitrophenol. Sorry, the nitrophenol group. And this we did find it in the COMT antagonist. So when you look at that compound, although it might look very complex, almost all the groups, you can be able to name the different groups are found in that compound. It's an imidazoline derivative, and it is used as an antidote. Mode of action and metabolism, this does not affect the neuromuscular transmission. I'm only saying this more often than not for your own benefit, to complete the information rather than leave the information hanging. This does not affect the neuromuscular transmission of membrane action potential. Dantrolene works by blocking the release of calcium from the sarcoplasmic reticulum of skeletal muscle cells by acting on the ryanodine receptor calcium channels. Because we said it is the ryanodine receptor or the calcium, the gated calcium ions that are defective, that they are abnormal. They release a lot of calcium and influence the muscle activity. They inhibit, so it inhibits excitation, contraction, coupling in the muscle fiber. So that's how it works. It is a drug of choice for the treatment of malignant hypothermia. It should be hypothermia. Malignant hypothermia crisis. It crosses the placenta and can be detected in the fetus after maternal administration. That can be a bit risky. It is slowly metabolized to give the 5-hydroxy and acetamide metabolites. Formation of hydroxylamine during the metabolic process may be associated with liver injury again. So remember, I don't know whether you have done the other antibiotics. like the sulfonamide. The sulfonamides can be metabolized. Some of the sulfonamides can be metabolized to the hydroxyamine. Remember the amino group. The amino group can be hydroxylated. The sulfonamides have a para amino group. The amino group can be hydroxylated. When you hydroxylate an amino group, you get a hydroxyamine, and the hydroxyamine is usually carcinogenic. It's usually carcinogenic. Again, it is an electrophile. It can bind tissues. It can form an electrophile, bind tissues. And we are saying for dantrolene, that metabolite can be responsible for its liver injury or liver toxicity. But nevertheless, when needed, it can save a patient who has been given halothane and reacted to halothane to get malignant hyperthermia. It is available for intravenous use in vials containing 20 milligrams lyophilized. Again, there's a lot of aesthetics there. You should be able to understand that from your aesthetics lectures. Sodium added to 3 grams mannitol to improve water solubility. Once you give it as an intravenous injection, remember solubility is very important. So it's lyophilized and then added mannitol to improve water solubility. Remember, mannitol is a sugar which has very many hydroxyl group. It is it is actually a sugar having very many hydroxyl group. Used for the control of the spasticity resulting from spinal cord injury, stroke, and multiple sclerosis. So it can have other uses, but our need, why I brought it in there, it might look like it's out of place, but I thought it is important because you have mentioned that very major or terrible condition that can happen from use of halothane, and therefore I thought it is important for us to understand this dantrolene. So that is our dantrolene, and we're just looking at its absorbed. So that is the salt derivative. So it's absorbed, and once remember the salt will form an equilibrium with the lipid soluble, which will be the dantrolene free base. So it will be absorbed as a dantrolene free base. But understand the salt formulation is important to allow this compound to go into solution. Dissolution is always the first step. Once you have the drug going into solution, whatever now is in solution undergoes an equilibrium. You will have the polar one and the non-polar one. The non-polar one penetrates the membrane. You have a shift of the equilibrium again according to the Chatterjee's principle, and then the absorption happens until your drug is absorbed. So you have that is your dantrolene, which is a free base drug. You can see it has a nitro group there. It can undergo hydroxylation. And if you look at its hydroxylation, it's undergoing a hydroxylation on the imidazoline ring. So that is hydroxylation at that position 1, position 1, position 2, position 3, position number 4, hydroxylate. I think 5 position. They numbered them. I think they're starting from your position 1, sorry, position 2, position 3, position 4, position 5. So that's how I was numbering it as per the original imidazoline. So now we are numbering it depending on the substituent, where the substituent is, and of course where the substituent is, we are calling it position number 1. We must make sure that second nitrogen also has the lowest possible position. So position 1, position 2. The heteroatoms must always carry the lowest number possible, position number 3, position number 4, position number 5. So it can give us the 5-hydroxy dantrolene, and it can also undergo nitroreductase. You can see that. And undergo nitroreductase to give us the amino group there, as you can see, amino dantrolene. And this amino group, as I had said, is the one which can undergo hydroxylation also to give us the hydroxy amino dantrolene. So to give us the hydroxy amino dantrolene, and the hydroxy amino dantrolene is the one I have said it can cause hepatotoxicity. It can cause hepatotoxicity because and form a very potent electrophile. Then it can also, once it has formed the amino group, it can also undergo acetylation, kawaida acetylation, acetyltransferase. This one, we have said it's nitro reduction. This usually hydroxylation, usually catalyzed by the cytochrome P450 enzyme, and therefore it can undergo acetylation catalyzed by the acetyltransferase to give us acetyl amino dantrolene. So I thought sometimes even as we learn, it is also important for us to understand and complete the picture so that when we go out there, we are well informed, so that in case there is any halogen toxicity or any of the other volatile ether, general anesthetic toxicity, you need to understand that if you have dantrolene, you can give it intravenously, as we have discussed, and you could save that patient. And because we have said that that reaction is a genetic issue. It has a genetic issue, and therefore you cannot know who will react and who will not react. That with that, we can say again that is the end of the dantrolene. I mean the complete story of the volatile anesthetics. We also discussed, so we are done with the inhalations. We go to the next one, which is the intravenous. Under the intravenous, we mentioned propofol, we mentioned ketamine, and we mentioned the barbiturate. So we will discuss propofol, ketamine, and the barbiturate. So propofol, its mode of action, it enhances the GABAergic neurotransmission in the CNS. Remember GABA, gamma aminobutyric acid, it's a main inhibitory neurotransmitter. So when propofol enhances that neurotransmission, it will bring about depression. Again, it will bind its own site. It binds allosterically to GABA receptor at a site different from that bound by the benzodiazepines or bound by the barbiturates or bound by GABA. It binds its own receptor. So they look like this. Receptors are very complex and they can have many areas to bind. Remember, a receptor is just a group of atoms. Mostly a receptor is a group of atoms, or it could even involve a double bond or something like that. It's a group of atoms, and those atoms, more often than not, they have either electron deficiency or have electron excess in nature, all have a group that can assist in forming ionic bonds, so they are charged, or they have a group that can help in forming hydrogen bonds. And I believe you have mentioned all those bonds that are formed. All those bonds are formed because an area within this molecule, that specific area within that molecule, which we are calling the receptor, has some unique characteristic that can allow it to bind another group. So later, when we look at receptors, let us know they're just a group of molecules which have a good characteristic. It can be electron deficiency. It can be that they are charged. It can be that they have electron excess. It can be that they have oxygens. And once they have oxygens, they can't be able to form hydrogen bonds and all those things, type of bonds that you have mentioned. They can also be able to form hydrophobic bonds. So it binds allosterically again. That is important to note. Maintenance of anesthesia is achieved with volatile anesthetics or additional doses of it. So we are saying you can't fast give. Remember, you can induce. We did mention the intravenous general anesthetics, use them for an induction. So once you induct the patient with, you normally don't use the volatiles, but although we have seen some, of course, some of them have, it can be, depends again on the setup, the level of the hospital, what they have in stock. Sometimes they not all those things. There is, of course, the ideal, but where is the ideal? Where is the ideal followed? In many of our hospitals, they practice funny things. So we are therefore saying you can give propofol as an induction, general anesthetics. Then maintenance, you can follow with it, but propofol is very expensive. Or now you can follow for maintenance with the volatile anesthetics that we have discussed. It is more effective than pentasodium. Again, we are going to mention the pentasodium is a barbiturate. It's rarely associated with vomiting. Metabolism proceeds rapidly via glucuronide conjugation and sulfate conjugation in the liver. So if you look at that drug, already it has that group there. It can also undergo hydroxylation at that point, and then those groups can undergo oxidative, can undergo glucuronide conjugation. With metabolism, that is our propofol there. So here, please note this is an OH, so that a mistake there. So we are saying this compound can undergo straight to glucuronide conjugation catalyzed by UGT, glucuronide trans or glucuronide transferase, and you have it already has that group. Although you do have these groups there, the isopropyl groups there that can introduce a bit of steric hydrons, but nevertheless, glucuronide conjugation of that compound can happen. And once the glucuronide conjugation happens, to give us the propofol glucuronide, for sure you know now, the propofol glucuronide, highly water soluble, removed from the body. It can also undergo through cytochrome P450, again, oxidative hydroxylation of that position there. So this OH there, here, that hydroxyl group is an ortho para director. Both other positions are occupied. So the only position left for oxidative hydroxylation is the para position, and that can happen to give us that hydroxyl group there. And once that happens, you get the 4-hydroxy propofol. 4-hydroxy propofol, position 1, position 2, position 3, position 4, position 5, position 6. So you get the 4-hydroxy propofol. And then the 4-hydroxy propofol again can still undergo oxidative hydroxylation at either of those it can undergo glucuronic conjugation or sulfate conjugation at either those, but mainly glucuronic conjugation at either of those hydroxyl group. So that can form a glucuronide, that can form a glucuronide. I would expect this one to be in higher concentration because of the lesser steric hydrons, because this hydroxyl group is much freer. The other one has the isopropyl group, but surrounding that hydroxyl group. So either of them, on either of them, in this one, you can get the one hydroxy propofol glucuronide, and this you can get the 4-hydroxy propofol glucuronide. It was also found that that hydroxyl group specifically can also undergo sulfate conjugation. So it is the second one that can undergo sulfate conjugation to give us the 4-hydroxy propofol sulfate. Whenever, so this compound here, when you have that hydroxyl group there and that hydroxyl group, it allows this compound to undergo further oxidation to form the quinone. So you can see that double bond there, NADP, quinone oxidoreductase. So the enzyme that catalyzes that is the NADP. Remember, NADP or NAD or NADP is a cofactor. These are things that we have studied. We have studied flavine, we have mentioned pyridoxine. These are cofactors that are needed by these enzymes for their optimal function. So this one is using NADP, and the enzyme is NADP quinone oxidoreductase, and that, I don't know which would have touched, God. Yeah, oxidoreductase, and that is what, remember when you talk about oxidoreductase, it's an oxidation. It will result in loss of electrons. You can see NADP, quinone, NQO1. So NADP, quinone, oxidoreductase. It is an enzyme which will result in loss of electrons. Loss of electrons is equivalent also to oxidation. That becomes a quinone, and you can get the 2,6 diisopropyl in this name, and isopropyl. It's the isopropyl, that is propyl quinone. The isopropyl, I can't remember, can't see, let me see that correctly. Can't see the sign. The isopropyl by I have to check that. I can't read it properly. That one I had not checked before. The isopropyl can see, of course, it's a diiso should be diiso. It has two quinones. Quinone. I think it has been given a special name, but I think this bit here, which I'll confirm later, is because of the fact that it has the two quinones, the isopropyl open. Anyhow, I'll check it properly. I don't want to guess, but as I have said, that name is associated or connected to the fact that it has these two quinones. But you see, they also give some generic names, which you cannot know all of them. They give them generic names, and I think this is also a generic name, which is because of the B. I can see a B. So that is one of the other products. And again, when you see this product being a quinone, we know one thing about quinones. Quinones are potent electrophiles. Quinones are potent electrophiles. And because they are potent electrophiles, again, this drug can cause toxicity. That drug can cause toxicity because of the fact that it is a quinone. And that means this carbon here has a delta positive. Although this group here is helping a little bit because this group is pushing electrons in, but the quinone, as we have mentioned, even when we looked at the metabolite in paracetamol, which causes the toxicity, it was actually a quinone. So that is the metabolism of the quinone, and of the propofol. As I have said, propofol is a very good drug, but again, very expensive, not affordable for many people. Then we go to ketamine. Ketamine, and by name, ketamine is 2-chlorophenyl 2-methyl-aminocyclohexanone. Again, you can look at the structure. This is the structure of ketamine. You can see it has the phenyl group, a chloro group there. It has this very important methyl amino group, and then you can see we are calling it cyclohexanone. We are calling it cyclohexanone. When you look at the name, this is a cyclohexanone. And the cyclohexanone, we are considering that to be the parent compound. And therefore, this substituent at this position that we are calling this, we are considering to be a substituent. And this one, we are also considering to be a substituent. So that is why we are calling it. We look at the name, we are saying position 2 and then 2-chloro. Position 2, this is our position 2 here. So we are starting, I believe, from there, position 1, position 2 there, position 3 there, position 4, and so on. So this is position 1, and that is position 2. So we are saying 2, position 2, and then we have a 2-chlorophenyl. So if you look at this again, you look at this phenyl group, that's position 1, that is position 2. So that's why we are saying 2-chlorophenyl at position number 2. We are just trying to understand the name. Position 2, 2-chlorophenyl, and then 2-methyl amino. And that you can see at the position, the same position where the chlorophenyl originates from, we have also the methyl amino group. So that is why that name is, you can be able to understand it now. 2, we start with the position 2, and the 2 outside represents the position on the parent compound, and the parent compound is the cyclohexanone. So that's position number 2. So we say 2, that position, 2 outside, and then we have the 2-chlorophenyl, again 2-methyl amino cyclohexanone. So I hope that makes it clear. So ketamine hydrochloride is very potent, and it's a rapidly acting general anesthetic. Again, when we come to discuss the hallucinogens, we will put ketamine as a dissociate hallucinogen. So again, you have to be very careful when you're using ketamine as a general anesthetic. You have to be very careful. And ketamine is one of the general anesthetic that has been used also to cause a lot of havoc, to poison people, to poison people, to raise people's drinks, because it can be, although it can be, of course, it's an intravenous, but it is a very, very, very potent. It is a very, very potent very potent general anesthetic, and it's also a very powerful hallucinogen, as we're going to study later. It is a very potent, rapidly acting and general anesthetic. The S enantiomer, the S dextroketamine is more potent than the R levoketamine, S analgesic. So that means it also has analgesic activity, but the analgesic activity, as we are seeing, is stereospecific with the S enantiomer. Again, if you look at the structure, we'll be able to see that this is a chiral center there. Here the chiral center up. So that's our chiral center. So you can have, it's usually given as a racemic mixture where you have the RS enantiomer, but we are very specific and we are saying the S dextro enantiomer is a strong analgesic than the R levo enantiomer. So again, all this we can be able to establish from the structure. We had already mentioned its mode of action. We did mention it blocks the NMDA controlled channels, and we did mention this are controlled by glutamate, and these are the main glutamate with the call agonist glycine, and these are the main excitatory. These are the main excitatory receptors, and once you block them, then you will bring about depression. Suitable for diagnostic purposes and for surgical procedures that do not require muscle relaxation. That means if you are going to give, if you want muscle relaxation, it simply means you can give a muscle relaxant because it does not have any muscle relaxation activity. Indicated for children under 16 years because it causes wild dreams and hallucinations in older ones. I had already mentioned to you, it's a potent hallucinogen. We call it a dissociate hallucinogen, very potent. But you see, very specific again. Why? You can't understand because physiologies in different ages of people are different. It can be used in children under 16, not above that, because of the wild dreams and hallucinogenic effect, again, that drug can cause. We had mentioned its mode of action and everything else. Termination of action is due to the distribution from the brain into other tissues. So the termination of action is not just because of the metabolism. Again, for those who have studied the barbiturates, you understand what we call the distribution. When the compound has very high, and you can see this compound has good lipid solubility. When it binds the receptor, because of its good lipid solubility, it can move out of the receptor and move into the surrounding tissues. Once it moves into the surrounding tissues because of the receptor. So redistribution is one way in which we can terminate pharmacological activity, and you're going to mention more when we discuss the barbiturates. Metabolism, it's metabolized into norketamine, which is also an acting metabolite in the liver, which accounts for its long duration of action. So when you look at this, that is our ketamine, because you can see this. Again, whenever you see an amino group attached to an alkyl group, you know there can be oxidative end dealkylation catalyzed by cytochrome P450 enzymes. So you're just saying it's catalyzed by cytochrome P450 enzyme to give us the norketamine, because I have already said, yes, we have said the S has high activity, but it's given as a racemic mixture. We have said the activity in terms of analgesic activity, given as a racemic mixture, and the norketamine has 1/3 the activity of ketamine, and that results in a longer duration of activity. It can also undergo oxidative hydroxylation of the cyclohexanone ring. It can undergo oxidative hydroxylation of the cyclohexanone ring, and the oxidation, this is position 2, position 3, so it can be in position 4, position 5, position 6. Once it happens in one position, you do not have, it's not multiple oxidation, it's oxidation at one position. Again, we have discussed this in quite a number of drugs where you can have hydroxylation at different points. The minute one point undergoes oxidative hydroxylation, the molecule attains a bit of, it has that group, the hydroxyl group then can undergo all-glucuronic conjugation. So even as it is now, it does not have any primary group to a functional group to allow it to go phase 2 or phase 2 metabolism, but the minute it undergoes oxidation, either at position number 4 or position number 5 or position number 6, when you get a hydroxyl group at those positions, then you have a functional group that can allow the hydroxyl ketamine to undergo glucuronic conjugation to give us the O-glucuronide readily removed from the body. So that those also conjugated with glucuronic acid, as we have said, to give us the metabolite. And once it's conjugated, of course, the compound is readily removed from the body. So we are still on intravenous. I think, again, this should have been the first slide. I was supposed to rearrange, I forgot. When we talk about the intravenous and general anesthetics, again, we have mentioned those classes as dependent on the route of administration. The IV anesthetics are non-explosive solids. They produce rapid loss of consciousness, but insufficient anesthesia, unfortunately. They produce very rapid loss of consciousness, but insufficient anesthesia. And that is why we say we do induction, because they are rapidly acting. Then we give them the volatile anesthetic. Some of them, we say they cause very deep anesthesia. So that is why we do give the volatile general anesthetics for maintenance, and even because of the cost. The intravenous general anesthetics, they're usually quite expensive. Rarely used alone. Administration of oxygen is recommended, particularly with barbiturates and thiobarbiturates. We are going to look at barbiturates and barbiturates like methotrexate or thiobarbiturate like their penton sodium. So that this should have been our starting point. I'm sorry about that. Sometimes I also rearrange. But anyway, even if it is the last one, it still makes sense. So from there now, we have done ketamine as an IV, we have done propofol. Then we move on to the barbiturates. And for those who have done the barbiturates, you have done the classification of the barbiturates according to their duration of action. And when you classify them according to the duration of action, the duration of action is usually dependent on the lip of the barbiturates. The shorter the duration of action. And the short duration of action of the barbiturates is again because of redistribution, as we have mentioned ketamine. That those barbiturates with a very high lipid solubility, they will move very quickly, move into the blood very quickly because you're giving them IV. You put them into the blood. So from the blood, they pass through the BBB very, very rapidly. That's why we call them ultra short acting. Very rapidly get into the receptor, bind the receptor. But unfortunately, because of their very high lipid solubility, they do not stay on the receptor. They are deputized. They move out of the receptor. They move into the surrounding. And that is why barbiturates have a short duration of action, because of redistribution adipose tissues, and therefore the concentration of the barbiturate at the receptor goes down. And of course, we did mention the GABA receptor, and therefore short duration of action. I want this to get into your mind, because the short duration of action can be, for a drug, can be because of metabolism. Of course, even some of them we are going to mention because of their structure. Also, their rate of metabolism further increases or further influences their short duration of action and makes the duration of action even shorter, because they have groups within their structure that are highly susceptible to metabolism. Such groups include groups like the ones we have discussed, acyl groups. Whenever you have an acyl group, an acyl group is highly susceptible. Remember us mentioning tormentin when we were discussing the non-steroidal anti-inflammatory. It has a methyl group. We say the highly susceptible to metabolism. When you have an acyl groups are highly, highly susceptible to oxidative hydroxylation. Other groups that are highly susceptible to oxidation or to metabolism is when you have unsaturation, when you have double bonds or triple bonds, especially on aliphatic chains. Again, now you have an acyl group, and the acyl group also has double bonds. The acyl group has triple bonds that further increases the rate of metabolism. So when you look at these drugs, let us look for those, whether they have Alkyl chains, they have other factors I'll discuss on the way. But one of the factors I want us to look at, do they have alkyl chains? Do they have unsaturated alkyl chains? And do they have very high lipid solubility? For a barbiturate to be ultra short acting, it requires to have at position number 5, as we are going to discuss, between 7 and 9 carbon atoms, very high lipid solubility will not sit at the receptor to be redistributed and therefore have a short duration of action. So when you talk about ultra-acting barbiturates, I'm only mentioning for the benefit of those who have not done the other unit. For those who have done the other unit, they already know that we classify barbiturates first into long-acting and then into intermediate acting and then into short acting. All those, the long acting are like phenobarbital, which we use as an anticonvulsant. You're going to study that later. We use it as an anticonvulsant. That is long acting, low lipid solubility. Then we have go to the short acting. We have drugs there like amobarbital, butalbital, aprobarbital, and so on in that category, whereby now those ones are short. From there, we go to the ones, no, those are intermediate acting. We go to the ones that have now the short acting. Again, you are increasing the lipid solubility by changing the group at lipid solubility. And once you increase the lipid solubility, now you go to the third category, which we call the short acting. That is where you get secobarbital, pentobarbital. You will discuss all those again when you come to discuss these drugs as sedative hypnotics for those who have not discussed. Then now you go to the fourth category, which we now call the ultra short acting. The ultra short acting are either thiobarbiturates or barbiturate carbon content at position number 5. For those who have not looked at the barbiturate structure, you're going to look at it in a minute. So I want us to understand that these barbiturates, we are talking about the ultra short acting barbiturates, which we can use as general anesthetics. It is because, again, of their structure, because of their high lipid solubility, and because they have very high lipid solubility, they can undergo very high redistribution. So that is just a summary of what we are going to see. So they have already mentioned that. So their induction is very rapid, administered by injection as salts. Again, always you give drugs as salts to increase their water solubility, immediate onset, and very short duration of activity. You can see we have put very short, ultra short duration of activity, and that is why you are able to use them as general anesthetics. Thiopentosodium is our first one, and this is the structure of thiopentosodium. Let me make it a little bigger. Sorry. So when we look at the barbiturate structure, we say they are position. We start at this position. We can start. This is position number 5. That is position number 4. That is position number 3. That is position number 2. That is position number 1. And therefore this is position number 6. So you can see the barbiturates at position number 2. It's only that these are barbiturates. Most of the barbiturates, even at this position, they have usually a double bond O. So when we talk about thiobarbiturates, it is where the of the barbiturates, this position we are calling number 2, also has an oxo. So we actually call them 2, position 2, position 4, position 6. So position 2, position 2, position 2, position 4, position 6. In those positions, they have a carbonyl group at all those 4 positions for the kawaida barbiturates. But now for the thiobarbiturates, this carbonyl group at position number 2 is replaced with a sulfur group. Placed with the sulfur, now we call them thiobarbiturates. So when you talk about dipentasodium, it is a oxygen. Oxygen at position number 2 has been replaced with sulfur with increase in lipid solubility. When you compare oxygen, nitrogen, and sulfur, you find that oxygen is the one which has the highest electronegativity, followed by sulfur, and the least is sulfur. So because followed by nitrogen, sorry, and the least molecule with the least electronegativity is sulfur. So when you, that means also when you look at when you rate them, or you group them, or you grade them as per their lipid solubility, you find that now sulfur has the highest lipid, because when it has high electronegativity, it has high pool electronegativity. Remember, it is the ability to pull electrons, and when this has the ability to pull electrons, that means it has also very high ability to make the molecule polar, because so it will leave the other atom naked, the carbon naked, and once that carbon is naked, it will have a delta positive, and it will have excess of electrons, and therefore it will have a delta negative, so dipoles. So, and when you have dipoles, you have lower lipid solubility, because the molecule has charge, it has lower lipid solubility, and therefore when we arrange these molecules according to their lipid solubility, it will be opposite to their electronegativity. The one with the highest electronegativity will have the least lipid solubility. So when you arrange them in order of the lipid solubility, oxygen, sulfur is higher than nitrogen, higher than oxygen. And therefore, when we substitute a sulfur for an oxygen in the thiobarbiturate, we increase the lipid solubility of the thiobarbiturates compared to the barbiturates, and we have increased it because we have decreased the tendency to form dipoles. We have decreased the tendency to form dipole or to form hydrophilic molecules, and therefore the thiobarbiturates have much, much higher lipid solubility. And the minute we put, you can see this an SNA, because it has been derivatized into the salt. When you put an S there, that barbiturate increases in its lipid solubility, and therefore when it increases in its lipid solubility, to hit the brain very fast, therefore bring about its effect very quickly, but because of the very high lipid solubility, high redistribution, and therefore very short duration of activity. So that is one factor that we need to remember, that thiobarbiturates, because of the lower, of the higher lipid solubility of sulfur compared to oxygen, the thiobarbiturates have higher lipid solubility and therefore are classified as ultra short acting barbiturates. Of course, the other parts of the structure must be in agreement. But the thiobarbiturates that we have, the pentasodium, because of course also the other groups are in agreement, is an ultra short acting barbiturate. So that is one position which is very important for us to remember. When you look at this barbiturate also, you can see that position 1 and position 3, this is only that in this one it is drawn after it has undergone ketoino tautomerism. No, I cannot discuss all that because you will discuss that under barbiturates. I'm only discussing them as general anesthetics. So under normal circumstances, again, this structure is usually like that you have this nitrogen there, has a hydrogen there, and this nitrogen there, nitrogen there also has a hydrogen, and then here you have your double bond sulfur. But you see now you have derivatized into a salt. So you find that for barbiturates, you can find two scenarios. You have those barbiturates where both position 1, again, I'll call that position 1, position 2, position number 3. So you have two standard types of barbiturates. You have those barbiturates where then the nitrogens, they must have nitrogen at position 1 and 3. The difference is some of the barbiturates, one of the nitrogens has been alkylated. It has been substituted with small groups like a methyl group, one only. So in all barbiturates, for them to have activity, they must have one nitrogen which is bound to a hydrogen. In all barbiturates, for them to have any CNS, wacha hata kuongea juu ya anesthetic activity, even if they are going to have anticonvulsant activity, sedative hypnotic activity, one of these nitrogens must carry a hydrogen. If you substitute that one methyl group and you substitute this one methyl group, that barbiturate has no activity. It does not have any. You can have at either position 1 or 3, doesn't matter which one, they are similar. Can only be one being substituted with a small alkyl group, and usually a other class, that these two nitrogens, one of them for activity must be free, because the barbiturates, for them to have activity, they must exhibit what we call, they must be acidic in nature. For them to have activity, to bring about CNS activity, they must be acidic in nature. The acidic nature is brought about by the availability of at least one hydrogen, because that one hydrogen allows for what we call ketoinotautomerism. And we have discussed ketoinotautomerism even when we were discussing tetracyclines. So there must be one unsubstituted nitrogen carrying a hydrogen to allow the bit of CNS. We are talking about CNS activity. They can penetrate the BBB, but if both nitrogens are substituted, the compound will not have any activity. For barbiturates to have activity, they must be acidic in nature. The acidic nature is brought about by ketoinotautomerism that is contributed by the availability of one unsubstituted nitrogen. All right. So I hope that is clear to all of us. So this, like when we look at that pentasodium, both of them are not substituted. That is still okay. That is okay. They can either be both unsubstituted or one is substituted. Position, as we have said, number 2, number 4, number 6, there must be carbonyl groups for it to be a barbiturate. If you have another group, the compound acquires a different name. That means you can see it's a pyrimidine and with 2,4,6 trione. Pyrimidine 2,4,6 trione. That is the basic structure of the barbiturates. Now we go to the next position, which is very important. And this is this position number 5. For any barbiturate to have CNS activity, it doesn't matter whether it will be an conversant, whether it's a sedative hypnotic, whether it's a general anesthetic position. Again, I'm just drawing the positions as they are. This position, you can consider it to be in barbituric acid. It will have a hydrogen and another hydrogen. So what we are saying is that in barbituric acid, where you have this is a hydrogen and this is a hydrogen, barbituric acid does not have CNS activity. So I've said 2 compounds. Double substituted barbituric acid will not have any activity. Again, that is substituted on both nitrogens. Again, when you have a compound which is not fully substituted, where the 2 hydrogens which I have shown here, this hydrogen and that hydrogen is replaced by an appropriate group. I'm calling it an appropriate group because it can be a phenyl group, as in phenobarbital. It can be an alkyl group, and the alkyl groups can be of different sizes. And when the alkyl groups are of different sizes, the alkyl groups you bring in different amounts of lipid solubility. And now, depending on that group at that position, and how much lipid solubility it brings in, you will classify. The higher the lipid solubility, the shorter the duration of action of the barbiturate. So if, even for those who have not done, and that's why we are saying it's very wrong, because all of you should have done the anticonvulsant, the other unit first, so that when I come to talk about these barbiturates, I would have just gone over them very simply, because you have done the other unit. But unfortunately, one of the classes has not done that. But we will, of course, as I have said, and there has been issues in the arrangement of this units, but I hope it will be streamlined. So I hope you have understood something. Now, when you look at thiopentosodium, very important that the two hydrogens, as I have said, that are found in barbituric acid, because barbituric acid has two hydrogens there, have been substituted. You can see that is a 1, 2, 3, 4, 5. This is, if you look at that group, the whole of there, on its own, it's a pentyl group. So it has to be substituted with the correct group at that position. And then you can see this is an ethyl group. So the first point I want us to understand is that for barbiturates to have activity, both nitrogens, only one of either the two are unsubstituted or one is substituted. Both cannot be substituted. Number two, the other point I want us to remember is that for barbiturates to have CNS activity, the two hydrogens at position number 5 must be replaced with appropriate either aromatic, alkyl, or allyl substituents. They can be aromatic substituents, they can be alkyl substituents, they can be anesthetic activity. They cannot be aromatic. Cancel that out. They can either be alkyl and long chain alkyl or allyl substituents. Saturated or unsaturated, or they can be allyl substituents for general anesthetic activity. And therefore, when you look at thiopentosodium, kindly note it has an ethyl group and it has this methyl, you can call it, that look at this group and look at for the longest chain, it is 1, 2, 3, 4. So we can actually call it methyl butyl chain at that group, or it is a pentyl group at that position. And when now we count the carbon atoms, we can say carbon 1, carbon 2, carbon 3, carbon 4, carbon 5, carbon 6, carbon 7. For us to have general anesthetic activity, the carbons at position number 5 must be between 7 and 9 carbon atoms. They must be between 7 and 9 carbon atoms if that compound is going even to be classified as a general anesthetic, between 7 and, or ultra short acting, between 7 and 9 carbon atoms. And if you count again, 1, 2, 3, 4, 5, 6, 7. And then for thiopentosodium, in order again to potentiate its lipid solubility, there is now the oxygen of position number 2 has been replaced with the sulfur. I've already explained the sulfur further increases the lipid solubility. So those two characteristics, those two characteristic or structural features of thiopentosodium give it very high lipid solubility. Position number 5 has 7 carbon atoms. Position number 2, the oxygen of barbituric acid has been replaced with the sulfur to further potentiate on the lipid solubility and give this molecule very high lipid solubility. The lipid solubility is very important. It allows this molecule, by the time you give it as an IV, immediately, even before you can even blink, the drug has already gotten into the brain. It's given that person a knockout immediately, within very short time, gotten into the brain, given the person a knockout. But after the knockout, then the recovery for that patient is very rapid because the drug with its very high lipid solubility is moving to the surrounding. And that accounts for the rapid onset and short duration, rapid onset and short duration of these drugs. And I hope that is clear for all of us. I've tried to use that, especially for the benefit. I will still mention them later, but I've explained, I've gone into that because of for the benefit of those who have not studied barbiturates, because you need to understand we must have that intact basic structure, which is a 2,4,6 pyridine 2,4,6 pyridine trione structure. 2,4,6 pyrimidine, this is pyrimidine there, 2 nitrogen, pyrimidine, 2,4,6 pyrimidine trione, 1, 2, 3. That basic structure intact must be there. But we have said the oxygen of position number 2 can't be replaced with a sulfur, as in thiopental sodium, with increased potency in terms of general anesthetic activity, but decrease in the duration of action. The substituent at position number 5 must be between 7 and 9 carbon atoms for this compound to have activity. Another characteristic I want us to see from the thiopental sodium is this branching. This branching is also very important. The branching in barbiturates can either be at this point, as we see it here, or in some of them, the branching is at the end. If you go and check out the structure of aprobarbital, butarbital, you find that the branching with a methyl group is at the tail end, is at the ultimate carbon. So it's also important for us to discover, to understand that when the branching is nearer carbon number 5, the compound has much higher lipid solubility than when the branching is farther from the carbon 5. This is the point where it joins position 5 on the barbiturate. So when the branching is nearer position 5 of the pyrimidine trione structure, then the compound has higher lipid solubility than when the branching is farther from carbon 5. And that again tells us that is why thiopental sodium, the branching is done where it is done. It is not just like for flukes or just like that. The branching is done near carbon number 5 to further increase. The branching increases lipid solubility, and the branching will increase lipid solubility when it is much closer to position 5 than when it's further to position 5. I cannot discuss the barbiturates in detail because, as I've said, you will discuss barbiturates as a unit when you do, I think, PHA 2513. Not wrong. So you should have done it first, but I've discussed that for the benefit of those who have not done barbiturates, so that they may not feel like they don't understand. So we are therefore saying thiopental sodium structure, the NH with a thiocarbonyl and carbon 5 side chain consisting of an ethyl or an allyl plus an additional 5 carbon atoms. So we are looking at structure. It's an NH with a thiocarbonyl. This is a thiocarbonyl and carbon 5 side chains consisting of an ethyl, or it can be an ethyl or an alkyl or an aryl plus, and which, of course, this doesn't come out very clearly, which the allyl, the other group, has another 5 carbon atoms. So you have this 1, 2, 3, 4, 5 carbon atoms plus that group there, which has 2 carbon atoms. Again, we will see that that can differ in other compounds. It's widely used as an ultra short acting barbiturate. So you can say about thiopental sodium very specifically, it has a methyl butyl group at position, which is an alkyl group with 1, 2, 3, 4, 5 carbon atoms, plus an additional alkyl group, which is an ethyl group with 2 carbon atoms, as we've already discussed, to give us a compound with 7 carbon atoms, which actually now is in the class of ultra short acting barbiturates. So that's what that point was supposed to say. Why do they use ultra short acting barbiturates? The sulfur atom increases lipid solubility, as I have already mentioned, and facilitates its entry into the brain. I've explained how it increases lipid solubility. It is more, less electronegative than oxygen, and therefore brings in more lipid solubility. Does not allow for formation as in the oxygen. The short duration of action is due to partitioning from the brain into the surrounding tissues or the body fat. It's metabolized mainly by oxidative desulfuration. And again, these are not new things, these are things you have discussed. That is the first route of metabolism. And once it is metabolized by oxidative desulfuration, unatoa hiyo, unaweka oxygen there. And now the drug changes from thiopentosodium to pentobarbital. And now pentobarbital changes from a general anesthetic barbiturate to a short acting barbiturate. So I hope you can understand that when it is metabolized, it will be metabolized first of all by desulfuration, change of the oxygen of the sulfur to oxygen, and it will form another barbiturate, which is pentobarbital. And now the pentobarbital can undergo further metabolism so that it can be removed from the body. So again, kindly understand that the structure of the barbiturate is responsible for their classification, and it is dependent on their lipid solubility, both controlled by position 1, 3, and also position number 5. Ultra short acting barbiturate, rapid action, we have used mainly as an inducing anesthetic, has no analgesic properties, anesthetic state maintained by inhalation, either by nitrous oxide or by the others. It is a poor muscle relaxant. It possesses potent and conversant activity. It may be given to treat epileptic seizures that do not respond to other drug therapy. So you can't give it like for status epilepticus. It is stored as a solid white salt and needs to be prepared in sterile water to inject the patient. So usually these drugs, when it is in its salt formulation, you have also the water for reconstitution. So these drugs are usually given with the drug and it's the water for reconstitution. Again, those are things that you will study in details in pharmaceutics, but because unfortunately I've done all of them at the time I did, I can also be able to mention 1 or 2 points where it is necessary. So always remember that some of the drugs are reconstituted with sodium, but you will have the diluent in the package. And all you will do, take the diluent, take your drug, reconstitute, and immediately give the patient, because these drugs are susceptible to hydrolysis. They are highly susceptible to degradation. So if you reconstitute and you keep it, then you will be giving different patients. And of course, that's what you're doing. It is being done in theater. Rapid recovery, not due to rapid metabolism, as we have mentioned, but due to redistribution. So kindly know, differentiate. Yes, a drug, because of the alkyl structure, it has an aliphatic hydrocarbon. It you undergo metabolism through oxidative hydroxylation, but that is not what gives it its short duration of action. What gives it its short duration of action is its redistribution because of its high lipid solubility. It is due to lower concentrations caused by redistribution of the drug from the brain to the blood. This is made possible because of the salt form of the drug. It does not have any direct toxic effects on the liver or kidney. Although it crosses the placenta, it is a safe agent for induction in pregnancy. So we are therefore saying that drug, when you give it as a salt, it will get into the blood, high lipid solubility, it will go into solution because it is a salt form. Once it gets into solution, it will undergo equilibration, like move very rapidly across. And that's why we are saying it will pass the BBB because you give it as a salt. The salt is to improve its solubility in the blood. Once it undergoes dissolution in the blood, undergoes equilibration, you have the molecule that is anionized with very high lipid solubility, passes the membranes, gets into the brain, brings the effect, redistribution into the fatty acids, and then it moves into the blood, and then it gets into the liver for metabolism through desulfuration into the pentobarbital, and then after that, it is removed from the body. I hope you have understood that. Then you have, I don't know what it is time. Yeah, sorry, it's past time. I don't know, you have just kept quiet. Are you okay? Sometimes Muko sawa, mumekimya tu. We are 61, not very good. Out of 100, where are all these other students? Out of 100, we are only 61. But thank you for those ones who are committed. Masomo ni ya mtu. To attend, I can't do anything. Why? I'm sorry, I've taken some time with some of these barbiturates and so on, because it's unfortunate, as I have said, for some of the students, they have not done it. For those who have studied them, it is a walk in the park. They understand what I'm talking about. Do we continue or we leave there? Niambieni. It's 9:24. What's your position? Stanley, yes, Masai? I was thinking we'd finish today, but it's okay. We can stop there. We can stop there for today. But it's okay. You know, sometimes learning is also, you need to understand. And as I have said, my major problem here, especially for the barbiturates, is for those who have not studied. But as we go on now, we have only a few slides, about 3 or 4. So we should be able to finish a general aesthetics in the next lesson. Actually, we had the other lesson we had last time for the full time, we would have actually finished today. But we should be able, a few minutes, you give me another lesson, a few minutes, we'll be able to finish the barbiturates with vasorelaxants, very simple. And then from there, hallucinogens, those are quite exciting. And yeah, we are going to finish. And I'm very thankful for those of you who have been available. Life is a sacrifice. Life is a sacrifice. If you're ever going to make it in life, it is a sacrifice. Nothing good comes easy. If you want to learn the easy method, easy come, easy go. But with the sacrifice, you give me a few more hours this week, that this week and even next week, I can assure you, you'll be able to finish and you do a second cut marking. You have a lot of work to mark, but all will be well. So that now, because if I don't examine you on this second area, the exam only asks about one question. Why would we do a whole unit like this? We can do it next semester, whatever. These days I'm a bit flexible. I talk to my students. I want us to discuss, but we do not have the option of not having the cut. That option is not there, because if you do not do this second cut, then I have not examined you well. And drugs, the hallucinogens and stimulants, and even the muscle relaxants. So we will a second cut that we will. And class reps, both of you, I hope you are there. Kindly get me for time. The fifth years are doing their end of semester exam in the afternoon. Very much. And keep reading. Do not say because you don't have end of term exam, end of semester exams, you forget. If you keep reading these things, they stick in the mind. Even for me, I have to keep reading. I have to keep reading. If you don't read, they disappear. They are not part of our brain structure. No, these are things that can, these are external things. So you must keep reminding yourself these are components. Don't read it. So there is nothing embarrassing, but you keep reading. You forget today, I can't remember the openton. You forget, you go back and you keep at it on and on and on, because you should be doing your exams end of next semester. So that for 4 months, they should be doing the exams end of next semester, so that they move on to their attachment. And I believe they do their exams at the end of 5-3. So again, you carry it from 5-1 through 5-2 through 5-3, and then your exam will be at the end of the 5-3. I really don't love that system. It's also the system we had. But that means that you must be wise. Even as you go to 5-2 and you have other demands for 5-2, you have to keep reading what you did in 5-1. To me, it's a more challenging system than the end of semester system. But again, we must always accommodate change. And we are hopeful that although it might look challenging, the advantage of the young brain is that if you continue bombarding it with memory, an accident or something. So the trick here for you, those who are in 5-1, even you who are in 4 and every day to give, even if it's half an hour, even 20 minutes to your farm chem, half an hour to your pharmacology and so on. Keep reading the current and the past so that you do not get to that semester or to the second semester. Now, it will be really hard. And that is why at times you get mass failures when you do end of year, because people did and forgot. So with those few comments, class reps, let me have more hours, and I can assure you we'll be able to finish. Thank you very much, and God bless you.